Hello everyone, welcome to my channel Hub. Myself Dr. Jolsna, and this is the final session of the topic Diagnosis and Treatment Planning in Implant Dentistry. So we have completed all the important headings in our previous two sessions, and this session includes mainly treatment planning and methodology and also the digital tools in treatment planning. So before beginning, I request everyone to please do like and share my videos if you're finding them useful. And if you're new to this channel, Hub, please do subscribe and support me. If you have any queries, topic suggestions or feedbacks, you can either comment below this video or you can mail me at this mail ID. So without any delay, let's get into the topic. As per GPT-9, the treatment plan is defined as the sequence of procedures planned for the treatment of a patient after diagnosis. So in our previous session, we have discussed about the stress treatment theorem. That is, almost all the treatment related to implant dentistry should be centered around the biomechanical aspects of stress. This theorem was developed by Misch. Because the primary causes of complication in implant dentistry are related to biomechanics, Misch developed a treatment plan sequence to decrease the risk of the biomechanical overload. And this consisted of different steps, that is the prosthesis design, the patient force factors, bone density in the edentulous sites, key implant positions and implant number, implant size, the available bone in the edentulous sites, and also the implant design. We have already discussed this in our previous session in the stress treatment theorem section. So this is the treatment planning sequence evolved from the stress treatment theorem. And our treatment plan should begin with a clear idea of the end result, which should fulfill the functional and aesthetic needs of the patient. Now let us see the different steps involved in our treatment procedure. The first step is examination, which include clinical and initial radiographs. Then the diagnostic setup, provisional restoration and specific radiographs for implants. The diagnostic setup determines the number and position of the teeth to be replaced and also establish the occlusal relationship with the opposing dentition. And once the diagnostic setup has been approved, it can be used to construct a stent or a guide for radiographic imaging. Then comes the discussion of the treatment options and decision on final restoration. Then completion of any necessary dental treatment like extraction of hopeless teeth, periodontal treatment, restorative treatment, new restoration or endodontics, whichever is required. Then comes the construction of provisional or transitional restorations. Then the construction of surgical guide or stent, the surgical placement of implant, allowing adequate time for osseointegration, that is a proper healing time, and finally prosthodontic phase and the maintenance phase. So what is this provisional restoration or the treatment prosthesis? So basically this is used to condition or treat the tissues before the actual prosthesis is made. We can also call it as an interim prosthesis. So this helps to establish the design of the final reconstruction and is used by the patient throughout the treatment stages. So in many treatment plans, the provisional restoration plays an important role. Let us see the uses of these implant treatment prosthesis. So the first use is that it helps with diagnosis. So the treatment prosthesis may correct the existing occlusal plane, identify the extruded teeth and indicate whether endodontic therapy, crown lengthening or extraction is required to complete the final treatment plan. Again, it evaluates the psychological profile of the patient. It improves or conditions the soft tissue before the final impression of implant. It evaluates occlusal VD, TMJ issues, aesthetics, phonetics, hygiene, etc. And again, it helps in progressive bone loading and also protects the bone graft or implants during healing. So in this picture, you can see the patient has a collapsed occlusal VD and a poor occlusal plane. So here the final result is not clear, and so we can give an acrylic removable partial denture as a treatment prosthesis, which is used to re-establish and assess the proper OVD, jaw position, plane of occlusion, TMJ status, speech, etc. So usually we use a complete denture as a provisional restoration in case of completely edentulous patient. 2 weeks post implant placement this can be used, and we can also use partial denture. So these are acrylic dentures which allow easy adjustment to accommodate any changes in tissue profile following implant placement. Again, adhesive bridge work can also be used as the provisional restoration. especially in the replacement of single teeth or small spans in anterior regions. So here is a Rochette bridge that is used as a provisional restoration. You can see the head of the implant below the mucosa. Finally, fixed bridge work can also be used, particularly for patients having extensive treatment who are not prepared to undergo a period of time without a fixed restoration. So these bridges will have to be modified following abutment connection. So these are the different types of the treatment processes or the provisional restorations. So single tooth implant restorations. So we have already discussed about the different types of fixed processes and also the implant overdentures in our previous session. So these single tooth restorations are actually individual freestanding units not connected to other teeth or implants, and they are very much similar to our conventional single crowns and are normally cemented or screwed to the prefabricated or customized abutments. And usually we don't prefer cantilever units for these single teeth restorations. That is, if two adjacent teeth are missing, then it's always preferred to place two implants instead of cantilevering. And high success rate have been reported for single tooth restorations, particularly those replacing anterior teeth. Replacement of single molars is more problematic because of the size discrepancy between implant and tooth and also the high occlusal loads. Therefore, either wider diameter or two standard diameter implants can be used in case of replacing a molar. So for these single tooth restorations, immediate implant placement is preferred to delayed placement because the height of the alveolar bone is maintained. And this is especially important in case of anterior portions of the jaws because of the need for enhanced aesthetics. So the main advantage of this immediate placement is that it shortens the treatment time and also improve aesthetics by preserving the soft tissue envelope. But it's not recommended in cases of periapical infections and also inadequate bone. In such cases, delayed placement and bone grafting are necessary. And another important drawback of the immediate implant placement is the jumping distance, which is the residual space between the implant and the socket wall. So this happens because of the differences in the socket anatomy and the implant design. So this jumping distance can lead to bony resorption and formation of bony defect, thus compromising the primary stability of the implant. So if the jumping distance exceeds 2 mm, then grafting procedures are required. Coming to the rule of 5 triangles. So to achieve excellence when placing immediate implants, diagnosis and planning of the case must be precise. In the year 2014, European Association for Osseointegration proposed the 5 triangle concept, which included 5 key aspects to consider during the decision making process to help prevent blunders that can lead to difficult aesthetic situations. So these key factors were represented by triangle, as you can see in the picture, and the first triangle is the presence of a buccal plate. So this is the first triangle, that's the presence of a buccal plate. That is, at least 2 mm of buccal bone is required in order to preserve aesthetics. Then the second triangle is the primary stability, which you can see over here. So this is the primary stability triangle. That is, an approximate 2 to 4 mm of bone apical to the alveolus is required in order to have primary stability. The third one is the implant design. So this is the implant design. So for the successful immediate implant placement, root form self-threading implants are required. So these implants should be engaged to the lingual cortex and hence it should be self-threading type. So this is a third triangle. The fourth triangle is filling of the gap between the buccal plate and the implant. So this is the fourth triangle. So this is what is called as the jumping distance, which we have already discussed. This gap should be filled with graft material. And finally, the tissue biotype. So this is the final and the fifth one. So a patient's gingival biotype is very important. It is more favorable if it is thick rather than a thin gingiva. And if there is presence of highly scalloped gingiva, there is chance that there is larger discrepancy between facial and interproximal bone, leading to increased risk of recession. And also we have to consider the interdental bone as it is equally important in influencing the overall architecture. So this is the 5 triangle concept which helps in the success of immediate implant placement. Next, let us discuss the bone density, which is a key determinant in implant treatment planning. So the diagnosis of bone density in a potential implant site is very important for the implant success, as it is related to the strength of the bone, the modulus of elasticity, the percentage of bone implant contact, etc. So we have already discussed about the different types of bone densities as per the Mish classification, and there is a tenfold difference in bone strength that is observed from D1 to D4. And also we know that strength of the bone is related to the amount of mineralization. So the bone is 60% mineralized at 4 months after implant surgery. And so it is important to wait longer before loading an implant. If the bone is of D1 and D2 type, you can give a 3 to 4 months healing period, and 5 to 6 month healing period is beneficial in case of D3 to D4 bone. So as the bone density decreases, the strength of the bone also decreases. So to decrease the incidence of microfracture of the bone, the stress and strain to the bone should be reduced. That means we have to reduce the biomechanical overload. And there are several ways by which you can do this. You can make the angle of the load more axial and prevent offset loads. Narrower occlusal table should be designed, splinting the crowns of edges and implants, and cantilever length can be reduced or eliminated in case of full arch restoration, and you can prefer RP4 prosthesis rather than a fixed prosthesis in edentulous patient to reduce the nocturnal parafunctional forces, and RP5 prosthesis can be considered in order to permit the soft tissue to share the occlusal force. Night guards and acrylic occlusal surfaces can be given which distribute and dissipates the parafunctional forces, and also you can consider progressive bone loading. And again, Mish has introduced several treatment plan modifiers when the bone density is less. That is, the stress can be reduced by increasing the functional area over which the force is applied. That is, you can increase the implant number, increase the implant width, reduce the cantilever, increase implant body surface area by modifying the geometry, increase implant length in case of D4 bone. So D4 bone benefits from relatively longer implants for initial fixation and early loading compared to other bone densities. This is because the stress strain transfer of occlusal forces extends farther down the implant body. So 12 to 15 millimeter long implants are suggested in case of D4 bone. And finally, increasing the implant surface condition, that is coatings or surface condition can increase the bone implant contact percentage and therefore increase the functional surface area, reducing the stress to the bone. So these are the treatment plan modifiers in case of decreased bone density by Mish. Coming to the factors that predict the implant prognosis. So it was Potter J.A. and Anthony von Fraunhofer who proposed the predictors of implant failures in 2005. So there are 8 factors. The first one is the bone type. That is, we know that D1, D2 are positive predictor, whereas D3, D4 type bone is a negative predictor. The next factor is the age of the patient. So above 60 years is a negative predictor. The clinical experience of the patient. So if there is good clinical experience, that is a positive predictor. Again, the implant placement and the location. The maxillary posterior placement is a negative predictor as the bone type is usually D3 or D4. And shorter implant is again a negative predictor. And the loading type, if there is axial loading, that is always a positive predictor, and we have to avoid off-axis loading. The systemic history, if it is present, it is a negative predictor. Dental history, again chronic periodontitis and also unresolved caries or endodontic lesions, etc. are negative predictor. And finally, habits like smoking, tobacco, parafunctional habits again are negative predictors. So these are the factors that affect the implant prognosis. Finally, coming to the digital tools in treatment planning. So now we know that the use of CT scanning and laboratory-based laser scanning technology, along with intraoral digital impression capture technology and with advanced software, help us to have an accurate representation of a virtual patient. And this concept has the ability to preview and even test different treatment options to enhance patient care, and it can also combine the data to develop a proper treatment plan for patient analysis and treatment. As a result, one can create solutions that would include all of the functional and aesthetic aspects of oral rehabilitation. So we have already discussed about fabrication of a radiographic template and surgical template by using CAD/CAM technology. And here let us see the prosthetic phase of an implant that is placed in the maxillary first molar region using our digital technology. So, before initiating the prosthetic phase of treatment, first the bone level around the implant should be evaluated using an IOPA, as you can see in figure 1. And then once the primary stability is confirmed, then the implant is exposed and a transmucosal healing collar is placed on the implant to allow for soft tissue healing for a period of 2 to 3 weeks. The next step is to record the impression. So in traditional technique, we make use of impression coping that are inserted into the implant at the time of impression. And then we use impression materials like polyvinyl siloxane or polyether that are used to record the impression. And then implant analogs are attached to the impression copings and a stone model is poured. So these implant analogs represents the position of the implant within this stone model. So this is the traditional technique. And here we make use of digital impression technique where we use implant scanner abutment, which is specific to each implant manufacturer. So we place the implant scanning abutment and then we take an IOPA to confirm the fit. And once the fit is confirmed, we scan the implant scanning abutment along with adjacent teeth to obtain the required surface anatomy. So this implant scanning abutment transfers the intraoral 3D position of the implant within the virtual digital cast. And we can provide the information to the dental laboratory regarding the implant platform diameter, position of the implant and also the desired emergence profile. And here we are not using any implant analog like that we used in the traditional technique. And next, to ensure proper vertical dimension and occlusal relations, the opposing dentition is also scanned. And after the arches are digitally scanned, the implant scanning abutment is removed and the maxillary and mandibular teeth are placed in maximum intercuspation to obtain a buccal bite registration. So here it eliminates the need to obtain the traditional bite registration for fixed prosthetic cases, reducing chairside time. And here we make use of computer software that automatically stitches together the multiple overlapping pictures in a transparent process called as real-time modeling, through which we obtain opposing arches in the maximum intercuspal position. So this is the digital impression technique. Now, once the satisfactory digital impression is obtained, then the electronic data from the digital impression are produced in the form of an STL file, which we have to send to the laboratory over the internet using the proprietary computer software. And once it reaches the laboratory, then it completely enters into a computerized world of scanning and fabrication. So in the lab, they can create a 3D virtual model and which can be rotated and viewed from any perspective, and then they design the restoration. So as per the database, they design the restoration, virtually place it and also correct the occlusion. And once the designing is completed, then it goes to the milling section where it is milled and followed by final finishing and polishing. So here you can see the customized abutment as well as the restoration, which is fabricated by a restoratively driven software. And here is the customized abutment placed in the implant site. So this is the implant crown that is finally placed and an IOPA is taken to record the to know the fit. So this is how we carry out the prosthetic phase of an implant by a digital workflow. Finally, concluding this session, so a complete patient evaluation and medical history is essential for obtaining the accurate diagnosis, determining the appropriate treatment plan, and also which helps to maximize the chance for success. So a diagnosis and prosthetic treatment plan should be based on accurate radiograph, the analysis with a diagnostic wax-up on mounted diagnostic cast, and also an estimation of the time to be allotted for surgery, the laboratory work, and also the clinical treatment. And The time spent organizing the treatment plan is valuable and will be beneficial for patient understanding. And our treatment plan should always begin with a clear-cut idea of the end result, which should fulfill the functional and aesthetic needs of the patient. And our goals should always be realistic, predictable, and readily maintainable. So these are my references. So thank you everyone for watching the session. If you have liked the session, please do hit the like button and also share it among your friends. If you are new to this channel Prosto Hub, please do subscribe to my channel and please support me. And if you have any queries, topic suggestions or feedbacks, you can either comment below this video or you can mail me at this mail ID. So it's a bye from Prosto Hub until our next session with a new topic.